Okay, good afternoon, everybody. Thank you so much, Dr. Manoj, for inviting me here. And I hope that you are guys enjoying having a good time listening to ERG and VEP, electrophysiology. Some physicians find that this is not a very good topic to speak, especially at the end of the day. But electrophysiology in general is a very interesting topic if you really understand it very easily and try to focus on it and to employ it where it belongs. Let's just talk a little bit about the multifocal strategies, and that would be very short and concise for you guys. Multifocal ERG, the concept of this multifocal ERG is that it looks like a technique that produces focal ERGs from the retina in order to get more information, more localized information from the retinal response. Instead of, as the doctor explained before, that the full field ERG is bringing only one single waveform summed up from the entire retina as a single response. But what happens in the multifocal ERG, that we get more than one response according to the degrees tested. Now, the stimulation here, it looks like a flicker, but it actually is not a flicker. It's small hexagons, the number of these hexagons ranging up to 241 in a multifocal ERG, and it's pseudo-randomly being flickering or changing in a specific order. We'll explain that in a minute. There is a sequence of this stimulation. What happens is that when someone looks at the multifocal ERG, he might think that this looks like a flicker or looks like a pattern ERG, that some pattern being reversed back and forth. But it's not. Actually, what happens is that specific sequence of projection of this small hexagon between different luminance and different contrast, between zero contrast up to 100% or maybe less. It can act as a multiple ERGs of the macula, but it's very important to emphasize that this is not a mini ERGs. It's not actually produced as one single ERG and then fractioned and fragmented over the entire retina. And the reason for this is that these waveforms is actually coming from extrapolation of certain summation of this sequence that we just described. So this is mathematically extracted signal. It's not a true signal representing each degree of the retina. This is basically the idea of the multifocal signal. I'll just try to explain that this is the pattern that we are having, and this is the sequence that we said. One time this hexagon is off, and the following time it's on, fully luminant, and this contrast what creates the response from the retina. And if you can see here, this is the distribution of these hexagons across different regions and different degrees of the retina. What happens here is that this mathematical linear and non-linear mathematical extraction of the signal being transformed onto the retina in something called the cross correlation. Now, the segments, as we said before, segments ranging between 61, 103, and 241. Each one is covering wider range and smaller degree of focusing on the retinal segment. Of course, these hexagons are cortically scaled, meaning that the center 2.5 degrees is more representing the fovea. That's why it's smaller and more crumbled in the center. And the more you go peripherally, the more it's loose and bigger. This signal is not like the single flash signal or not the pattern ERG signal coming as a single signal, and this is it. This is a continuous signal till the end of the whole cycles in the multifocal testing. When it comes to the analysis of the data, what the ISEV requirement is that this part of the the signal should be present in the analysis. This part we call it the first order kernel. Basically, the origin of the signal, it's coming from the cone responses. That's the main focus, because this is a very high luminant and very high contrast stimulus, so it's actually targeting your cone response. There is very little contribution from the inner retina and the ganglion cell. Some people say there's none, there's no. Unless if you modify the contrast and you modify the luminance, then you can get some contribution. And in fact, in most of the system available now, you can have a wide range of parameters you can adapt and you can change. For that reason, you can do some more research, you can do some more work of your own, but eventually the inner retinal contribution is very minimal. What you see here on top, this is the first order kernel analysis, and this is the second one. And the first one is basically reflecting more or less the cone function, and it's a linear summation. This is a non-linear summation. That's why the second order kernel, sometimes people do not consider it in their analysis. Now, when we are talking about the presentation, we have to keep in mind that the presentation of the signal is mainly topographic, meaning that you need to see the amplitude, the latency, in comparison to spatial degrees or spatial parts of the retina. What's the periphery to the center? What's this degree to this degree? And at the end, when you want to do the analysis of the data, you can normalize this amplitude difference, and you can come up with a good idea about how different the center from the periphery, how different a peripheral spot from the next spot, how different this peripheral spot superiorly to the peripheral spot inferiorly. So the topographic presentation is the main objective. These are the available types. The multifocal VEP, it was like a well-established research tool up to this moment, but it's available in many commercially available systems. But we can see here the variation that we just spoke about, that the central waveform is a little bit different from the peripheral waveform, and this topographic representation is the main objective. This is the objective that you can build your diagnosis on top of it. This is a comparison between the 241 and the 61 and the 103. This one on top here, the 61, this is the 103 segments. And you can see here, for instance, the blind spot represented here, the top one, as 3 pieces or 3 signals, and here represented by maybe 7. So the more segments you present or project on the retina, the smaller is the stimulus and the more focal information you get more. However, do we use this 241 as much? I don't think so. We use most likely the 103 and the 61. And the 103 is most likely being used on a regular basis. I don't know, because sometimes in different clinics, especially if you want to modify it and use it for research purpose, you have freehand wide range of parameters that you can employ and get some good ideas about things in depth. It's covering about 40 to 45 degrees of the central visual field. And as we said before, back to the topographic display. This is the multifocal VEP, and what you see here is this. It's covering also central about 45 degrees, 25 degrees on each side, with a nasal extension of 42 degrees. The only difference here in the multifocal VEP is that we are not using any retinal response directly, and we're not using the corneal electrodes. We are using a VEP signal response. So that's why we are using VEP kind of protocol for recording. But in order to make it more precise, we use 4 channels, not just a single channel. And there's a lot of research done on this specific type of multifocal testing, numerous within the last 10 or 15 years. And they were trying to employ the results in the early detection of optic neuropathies in general, including the glaucoma, of course. The clinical applications of the multifocal is probably obvious, which is the macular diseases. You can highlight some dystrophies, especially if it's congenital. You can highlight acquired problems like diabetes, the toxicity for the macula. You can start your baseline and follow up your patient and try to compare. Glaucoma is a big thing. It was studied very well in the multifocal ERG and more extensively in the multifocal VEP up till this moment. And of course, your strategy is the progression of assessment, of your initial assessment, and you follow up to see the progression. Just to give you an example about the clinical correlation, this is a case that you can see here, a normal representation, topographic representation. The center is well-established signal, and the periphery is usually lower. Here is the complete opposite. You can see that the center is well preserved and the periphery is very, very low. And that can give you an indication that this patient has some peripheral restriction of field of vision. This can be produced by many diseases, including RP, including even heavy laser can give you this picture. Someone has PRP, heavy PRP, can give you this kind of picture. Here, the opposite of the problem, you can see that the central is pretty much lower, and topographically the 3D representation also can show that multiple islands of depression. But of course it's not very bad enough to say that this is a total depression. The one on top, you can see that it's almost flat in the center and also represented here in the 3D representation. So this could be coming from the same patient with like few months apart, and you can see the progression, how it goes. In the multifocal VEP, we find it very, very important to interpret the results with other interpretation with other data. This is a visual field from a glaucoma patient, and if you do multifocal VEP, you can get exactly the same defect. The difference is this is functional, but the only problem is that the visual field test is considered as subjective test, low reliability, have a lot of problems in the test taking itself. But if you look at the multifocal VEP, it's the opposite. It's objective test, and it can give you more solid information. Even anatomically, when you check the OCT, you can see that the OCT also can give you some clue about specific sectoral loss, and you can confirm that with the multifocal VEP, and you'll find it's matching. There are some limitations in general for the multifocal testing. Number one is the normal values. There's a big range of normal values, even centrally and peripherally. That's why it's a little bit more difficult to standardize the test. All what's available now is guidelines from the ICEF, and it's very hard, theoretically at least, to standardize all the data. There is a range of accepted amplitude and latencies, considering that this is an ERG waveform at the end. But in order to standardize it to that extent and make certain limits, we are still a little bit behind this. Repeatability of multifocal testing also is an issue because everyone has a topographic map of the visual cortex different from the other one. That's why even it's more difficult in the multifocal VEP because everyone is different from the other. That's why you can repeat one test and even the same patient repeated, you move the electrode a little bit and you start getting different data. Early detection versus progression monitor. Is it good enough to early detect any diseases? This is a question mark here. But progression monitoring, yes, you can monitor progression for both macula and for optic nerve diseases. Of course, we need some future research on this subject, and that's happening very much at the moment. Conclusion, the multifocal testing still complementary data, but it's very, very important data and many diseases, especially the macular diseases. The multifocal VEP, there are tons of literature now published about how valid this multifocal VEP in the glaucoma assessment, especially in the well-established defects, and there are some research now being running for early detection of glaucoma and optic neuropathy in general. course, it's feasible test, very much affordable and convenient, and there are promising future research in this field. And thank you so much for this.